Welcome everyone to the sponsored seminar titled IOUS Guided Liver Surgery, The Need of Standardization. This session is sponsored by Fujifilm Healthcare Corporation. Today's session, we have Professor Kiyoshi Hasegawa from Tokyo University as a chairperson. Professor Hasegawa, please start the session.
Hello everybody, I'm Kiyoshi Hasegawa from Tokyo University. Today, I invite the very famous HPV surgeon, Professor Guido Torzilli, as a speaker. First of all, I express my sincere thanks to Fujifilm to support this session. Professor Torzilli is a very famous and HPV surgeon worldwide, and core member of the EWALT Association, and also a very good friend for me and the University of Tokyo. I think everybody knows him well, but I will introduce shortly him. He started the medical career as a surgeon in 1988 in Milan University, and after that he stayed in Tokyo University Hospital for 2 times and obtained a PhD. And now he's now a professor and the chairman of the Department of General Surgery in Humanitas University in Milan. He's an expert in the intraoperative ultrasound and have wrote many papers about this topic. That is why the reason why the sponsor Fujifilm strongly recommend him as a speaker in this session. His topic is about IOUS guided liver surgery, the need of standardization. Professor Torzilli, please start your lecture.
Thank you very much for the kind introduction, and thank you very much for Fujifilm for involving me. And of course, I'm pleased to join this session, either for the argument and for the meeting EWALT. That is the 4th edition, and we started in Milan in 2015. Now I share the screen and let's start my talk. Well, US guided liver surgery, the need for standardization. Well, we have to consider that surgery has pushed its capability to address the need for treatment for patients with liver tumors, and a category of them where this kind of treatment has exploded. This potentiality is the one of the multiple metastasis from colorectal cancer into the liver, in which several solutions have been devised in the years, but some limitations still exist. And then I'm just challenging the audience to foresee a surgical possibility for a condition like the one that you can see on this CT. This patient underwent chemo, some lesion disappeared, but anyhow, this technical solution in reality did not change in terms of resectability. This is the cast that we did for this patient, and in green you see the still visible lesion, in the pink color the one that disappeared. And this is the strategic clue for devising, for trying to foresee a solution in this patient, which is facilitated by this fact. Well, the solution for this patient probably cannot meet dose conventionally proposed in the surgical approach to the liver according to the Brisbane classification, the major hepatectomy and those limited peripherically located. Even the more commonly adopted strategy in this setting of disease, the so-called stage procedure, the two-stage one, would not be adequate for this patient because of the distribution scattered elsewhere, everywhere in the organ. And then, according again for the simulation, we couldn't imagine a future liver remnant enough for warranting the success of the procedure, even the enhanced two-stage, I mean the so-called IOUS, would not be profitable for this patient, possibly, according to the fact that anyhow the remnant liver would have been even inadequate for this approach. In the years, thanking to the guidance of the ultrasound, the knowledge of the liver anatomy, we have proposed several solutions, alternative to major resection in case of complex presentation. And possibly with this kind of approach, we will see if there would have been, if there could be a solution to this patient condition. The modality for which we could achieve the possibility to address a solution for this patient pass through 4 points. One is a detailed strategy, which is a very important step for planning the eventual operation. And in this sense, the 3D cast is essential, as facilitated and boosted this kind of approaches through the evaluation of 3 aspects. One is the volume. The volume for solutions which are based on quite complex liver dissection, quite complex technical solution able to maximize the sparing of the parenchyma despite the scattered distribution of the lesion was almost impossible with just evaluating the volume according to the major hepatic vein and considering the major hepatectomy. While with this technique, with the 3D cast, we were able to plan and simulate in the fact the operation and to foresee previously the future liver remnant, estimating its value, which was in the study that we published on HPP quite in line with the real future liver remnant that we encountered after surgery. Then we can nowadays have the ability to foresee which will be the future liver remnant despite the complexity, the 3D complexity of the dissection of the liver. Find the technical solution which minimize the volume of organ needed to remove all the clusters and maximize the amount of liver in this way that you can spare. In this condition, 4 cluster, 3 major one can be visualized, and 3 other isolated nodule has to be removed separately. The third aspect are the search for the compass point, which on one side characterize the cluster's border and identify at the end the resection area. And this kind of compass point are represented by those lesions into the deep of the liver in relation with the major vessel into deeply located in contact. Like in this case, we have a lesion behind the middle hepatic vein, attached to the middle hepatic vein, close to the cava confluence, and another lesion which is behind the dorsal aspect of P58, the right anterior branch. And other lesions are those that characterize the peripheral aspect of the clusters and of the area that we wanted. Then in yellow, the deep lesion, yellow flags, and in blue flags, the lesion at the border of the area. And the resection area is that one that we were going to plan, is the one that you can see in the red and orange arrow, in the yellow and orange arrows. Orange are those who are posteriorly located. The yellow is the dissection line anteriorly, superficially located. The other aspect is, of course, not only this aspect, but also some surgical oncology details that encourage our possibility to do these operations. The R1 vascular. I mean, we all know that our target should be R0, so removing enough, removing the tumor with enough liver parenchyma surrounding the margin and separating the margin from the border of the lesion. The R1 is by necessity, but preferably not, R1 parenchymal, but we didn't know exactly what would have meant the detachment of the tumor from a vessel, the so-called what we named R1 vascular. And we have shown after several years of front detachment that this kind of detachment is could be assimilated to the R0 surgery in terms of local recurrence risk, while the R1 parenchymal was for the colorectal liver mets inadequate in an oncological point of view. This is further enhanced once you are considering the hepatocaval confluence. Why? Because contrarily with on the opposite of the Glisonian pedicle, for the hepatic vein, you can also remove part of the vessel wall and spare anyhow the vessel. And then you have two possibilities. One is the detachment, if suitable, or the partial detachment with a partial resection of the infiltrated vein wall. In this way, we saw that the vast majority of the patient with the contact of tumor in contact at the caval confluence with colorectal liver mets could be detachable. 1/3 can be detachable with partial resection, and only a few one needed patching for sparing the vein. And this detachment find is rational by the fact that Lenneck described the capsule that surround the major vessel into the liver in the 17th centuries. And this notably finding was dictating us that in the fact the major vessels are something separated by the liver parenchyma, not only by the vessel wall and the Glisonian capsule, but also by this capsule that is further separating and then sustain our idea of something different from the R1 parenchymal of the R1 vascular. The third is the adjustment that the liver provides for these conditions. Indeed, once you have condition in which you cannot separate the tumor from the vein because the vein is completely invaded, like in this condition in which the middle hepatic vein is completely invaded by the tumor occupying the segment 1 paracaval, the segment 8 and the segment 4 superior, well, and it is in contact with the right hepatic vein and the left hepatic vein at the caval confluence, the liver itself provides the solution to overcome these invaders, which is represented by the tumor. The development of collateral circulation is almost constant, especially if you see at the preoperative setting that the enhancement is okay and the EOB of the MRI show a complete good enhancement of the organ, despite there should be a part of that theoretically would not be drained by the hepatic vein invaded by the tumor. But in reality, this is sustaining per se the existence of this communicating vein. In this case, we had at least 2 circulation, and this was possible to allow us to remove the tumor completely in the so-called liver tunnel that we described firstly several years ago. And then the resection of the vein and the detachment of the other 2. The last aspect is the guidance. The guidance is based on the tradition. The intraoperative ultrasound, fingers, vessels, disappeared lesion are important element. The intraoperative ultrasound make transparent the organ. I should not teach anything to my Japanese colleagues, since this is something that is coming from your country and from my master, Professor Makuchi. And the fingers are, of course, the indicators of the landmark for the trajectory that to be followed intraoperatively, targeting the direction of the dissection, and then enabling us to drive even with complex position postoperatively, like in this case in which we position the hand behind the liver and in front of the hepatic vein to draw the dissection plan as we were planning and proceed with the resection. The other aspect is the anatomy of the organ, which drives us during the dissection. And then the major vessel has always branching vessel just beneath the surface of the organ. This is the middle hepatic vein, peripheral branch just beneath the Glisonian capsule. We follow it, we achieve the vein, we have to resect the tumor, the vein, because it was infiltrated. And then we resect the vein, but we met just below the left portal vein. We follow the left portal vein and we encounter the dorsal part of the P5-8. We had to resect P8, and then we opened the angle between P8, P7, P6-7 and the right hepatic vein. Following the right hepatic vein, we completed the tunnel also in this case. And the last aspect is the disappeared lesion. We now have the possibility to overcome the problem related to the disappearance of the lesion due to insisted or to anyhow chemo preoperatively, usually done in this case, knowing the position with the pre-operative CT or MRI, which is uploaded on the ultrasound system in relation with the major vessel, even if we cannot see clearly in the EOS image, we can understand the position where we were and according to relation with the major pedicles. In this way, we have the pre-chemo cast preoperatively done in this case with 37 lesions approximately scattered in the liver. The preoperative MRI was not showing, was showing just 4 or 5 lesions. The most of them were disappeared. According to what I show you with the fusion imaging, we identified the compass point, the cluster, and then we combined almost the same image with the ultrasound, and we follow the dissection and plan the dissection intraoperatively done. In this way, it was possible to draw the resection area and to carry out the resection in a conservative point, and this is the compass point. The results of this approach is that we reduce to exceptional condition the parenchyma, the major hepatectomy, while in this complex situation, the parenchyma sparing were possible in the vast majority of the case. Here is an example in which we have the preoperative, the pre-chemo cast. We used anyhow also in this case the fusion imaging. We define the clusters, the 2 major clusters. We saw the compass point, the dissection. We did so intraoperatively, and we removed 83 colorectal liver mets in a single procedure. Safe complexity, yes, in this way we can control everything. We have the possibility to foresee the future liver remnant, and then we really maximize the number of lesions to be removable in a conservative way. In major hepatectomy are less than 10% in our series, up to 83 lesions. The mortality is really minimal, 0.1%, or 3 cases, 42% with more than 10 lesions, and 75% of at least a major contact, and bilaterally 35% of our series. The bilateral contact, formally those who are unresectable in terms of whatever you are proposing, anyhow have survival which is not statistically different with R0 and a single R1 vascular representation. In terms of safety, when we compare this kind of surgery to the standard of reference of the major hepatectomy, we see that there were better outcome, except for the higher rate of bileak of the complex core hepatectomy, which anyhow now decreased with the routine use of the air leak test. Salvageability is an important issue. The possibility after such kind of removal in this patient, we removed a lot of lesion, 36, 37. We were able to spare just this thin layer of the parenchyma, including anyhow the hepatic vein and the Gleasonian pedicle to P8 ventral 1 and 2, detaching here a tumor, and then we maximize the sparing of the organ. We remove part also of the left lobe, and we had the recurrence. The patient could be reoperated either in a conservative way, and there was another detachment with the mid-hepatic vein. The re-resection for the liver-only liver recurrence was possible in 62% of our patients. Its relation with the tradition. Tradition means two-stage hepatectomy. We did this paper that was showing how comparing our series with those of Paul Bruce and having the criteria, inclusion criteria set by the criteria for the two-stage hepatectomy. We show that the one stage provide better results in an intention to treat, overall survival for an intention to treat perspective, because we have no, of course, dropout. And this is also securing in terms of long-term survival from recurrence-free survival, which is not dismal compared to the two-stage procedure, despite in a one-stage perspective, we include those patients that would have not passed the two-stage of the staged policy. We were challenged by the Italian registry of ALPS, and they couldn't achieve the same complexity of our cities. There were 12 centers versus our centers. We had to do a case match 1-to-2 rather than 1-to-1. So we used 52 patients versus 26. While in terms of safety, there was blood transfusion and the risk of liver failure. There was no discussion. It was favorable for enhanced at one stage. Of course, R1 were more present in the enhanced at one stage rather than in the ALPS. The survival were equal. Then we are treating more advanced disease with lower mortality and equal long-term reproducibility. In my team, nowadays, more than 50% of the procedures are done by my staff. They started doing that autonomously at the age of 31, and nowadays they have their mean age is 39, and they are doing quite a lot of procedure, despite the complexity of the patient that we are used to treat. Where we are here. This is the patient that I showed. This is the patient that initially I discussed. This was the liver cast. This is the simulation of the procedure. This is what we have done according to this strategy planned preoperatively, and this is what we did intraoperatively. We know that there was this tiny lesion behind the middle hepatic vein. This is the specimen going to be removed. This is the ultrasound. We saw the vein. We confirmed it with the contrast analysis intraoperative ultrasound. This is the major vein here at the contact with the cover confluence. And then we had to detach and remove partially part of the middle hepatic vein, which was completely speritonized. And at the end, the removal was completed with the dissection here shown in a circle, what we named as a roller coaster hepatectomy. Where we are going, it's a stepwise dialoguing path, dialoguing with anatomy. We have shown the possibility of enhancing the conservativity even in complex procedure, then increasing the number of solutions that are offered by such a fantastic and complex, fantastic organ, fantastic just because of its complexity. Then challenging the complexity and following, taking profit of its complex anatomy is the secret for this approach, making feasible essentially now by the possibility to foresee the volume, to foresee the strategy, and then to somehow have the direction for a standardization of this procedure, thanking to the preoperative strategy that is now possible to detail in very quite accurately. This kind of surgery is a parenchyma sparing, vessel guided, in the fact, major hepatectomy, because we remove a lot of organ, but we are sure that we leave enough organ to remain. And nowadays, with the possibility to estimate the volume, we can also estimate which is the growing pattern of the organ after such kind of resection rather than the major amputation, which are being compared in the study that is going to be released. This kind of strategy has been represented this year on the British Journal of Surgery, the cover of an issue. And it's something that I think has brought the border of the surgical, the limit of the surgical technique far ahead to allow us to face with more complexity. In future, possibly, the only alternative to this kind of approach will be not the stage procedure, but the liver transplant. Thank you very much for your attention.
Thank you, Professor Torzilli, for your informative lecture with a challenge, your challenge in the surgical treatments for colorectal liver metastasis and excellent outcomes even in the patient with too advanced, too many colorectal liver metastasis. Thank you so much. Are there any questions in the chat? We have sufficient time to discussion, 30 minutes. So as for the first question is about strategy. You mentioned about 4 points to improve the surgical treatments results. The first one, the strategy, included the volume and the cluster and the compass point. I would like to have a first question about the volume. You mentioned the volume can be evaluated by the 3D simulation, but I sometimes wonder about functional volume if the where the outflow way is obstructed. In such a congested area, the functional volume can be estimated. How do you think about that? What do you think about that?
When we do the preoperative imaging,
yes,
we estimate the enhancement of the organ, for particularly with the MRI, which is routinely done. And once there is no decreased enhancement of the part of the organ that theoretically should be drained by the invaded vein, we are pretty sure that this liver is perfectly working. And normally in this patient, you also see the preoperatively already the communicating vein. And the other aspect is that our limit is according to the Kubota's paper, so very old, but still adequate, still to me very informative. We don't want to go below the 40% of the organ remaining. We do not push too much. Despite it seems that we are pushing, in reality we preserve at least maximum 35, 40, below 35 never. 35. Sometimes we accept 37, 38% of the organ. And normally the perfusion should be nice. Otherwise, we could not, if we do not see an adequate contrast enhancement, we consider that part of the liver not working enough.
You also mentioned the presence of collateral pathways when the major hepatic vein is resected. Can we know the presence of collateral pathways preoperatively?
Yes, as I said, most of the time the imaging is showing them even though not completely, but we have there is a semiology that allow you to understand if there are those can be seen with the MRI, and we use also to do the CT for these patients. These complex patients undergo both procedure, and this aspect, together with the kind of enhancement of the parenchyma, ensure us the existence of these veins, and which can be confirmed usually with the E-flow, as you know, in the intraoperative setting.
In our institution, if the collateral pathway is not so clear, we aggressively perform the reconstruction using the venous graft. What do you think about the significance of venous reconstruction? Do you perform that?
It's a debate I have with one colleague in Italy who is nowadays is drawing his fame among the HPB surgical community. Is Urbani in Pisa, who was one that was following us, he visited us. He has a transplant background, and he pushed a lot to do the same procedure that we do, but mostly using bypass. I must say that we have never done it, and of course there is a bias of selection. Possibly we have excluded those patients that we considered not resectable, those patients that could not show in the preoperative setting the adequate enhancement and the visible presence of collateral communicating vein. But in the fact, this could be a bias, but I have not consciousness of this bias in the fact. Anyhow, I think when there is a major occlusion of a vein, there is always a possibility of, if the liver is well perfused, it means that there is a collateral circulation. Otherwise, there should not be, because it means congested, long-term congestion of the organ.
Okay, and I am also interested.
I mean, if possible, I don't like to increase the complexity with the shortcut of the vein reconstruction, because in the fact it provides probably with the cadaveric vein as you use the risk is low, but in example using the graft, the risk of occlusion is not negligible. Then to me it's safer the communicating vein, which are a natural bypass.
Okay, and I'm also interested in the significance of R1 resection. You divided the two types, R1 vascular and R1 parenchyma. And I have one question about that. If the chemotherapy is effective in such a situation, how can we know which is the best way to choose the resection type, R1 vascular and R1 parenchyma, if the chemotherapy is so effective? So maybe the tumor is almost necrotic. Is it possible to perform a R1 vascular in such a situation?
Yes, the limitation for the R1 vascular is the kind of growing pattern of the metastasis, with the tumor that are replacing the tissue infiltrating is more is higher the risk of recurrence of the R1 vascular. Now we have the data is going to be published. Another aspect is, as you have seen, possibly we have to reconstruct some vein with partial resection, despite the tumor were quite tiny. And this happens paradoxically more frequently after the chemo, because the reaction with the tumor and the restriction, if the origin was at the contact, not in the parenchyma, when the tumor grow up, make more difficult the dissection between the vein and the tumor. And in this case, is more frequent the need for partial resection. What generally the rule that I learned by Professor Macucci is that once you have a contact, the real contact is always less than what the imaging is showing. Then you can gain always the part of the vessel wall that can ensure you most of the time the direct suture, not even the patching, and then the sparing of the vein. I mean, then I think if there is a reduction in size and a necrotic part into the liver does not impact the results of the one vascular, you have to consider that those who joined our study were almost always underwent preoperative chemo and always successful. Nowadays, we are not almost authorized by the oncologist to proceed to surgery in the multidisciplinary setting if we don't have a response. I am not sure that is a good thing. Sometimes the patient refuse chemo and then we proceed and the results are not dismal, but objectively, common sense, we accept the neoadjuvant always. And most of the patients had not in reality a neoadjuvant approach, but they had a real full course of chemo because we are considered unresectable before in the center from where they come by the oncologists themselves.
Thank you. And as for the parenchyma sparing hepatectomy, I would totally agree with you. The parenchyma sparing is a good choice and first recommended in the treatment for the colorectal liver metastasis. I was surprised that the proportion of the parenchyma sparing hepatectomy is more than 99% in your institution. It's very high.
In the series with the hepatic vein, that series was not the multiple bilobar, was the series of those patients with tumor at hepatocaval confluence in contact with the hepatic vein, which means that there could be also one lesion. And in this sense, we almost never do the major hepatectomy. Major hepatectomy means that we don't do the right hepatectomy, the left hepatectomy. The upper transversal hepatectomy, in which we remove segment 7 and 8 and 2 vein, segment 7, 8, and 4 superior, and 2 vein, the middle and the right, is formally could be considered a major hepatectomy, but is a limited resection because we remove a major tumor invading all these 2 veins. And we remove only the disease and a few amount of liver parenchyma.
I think the proportion of major hepatectomy is very low compared with my institution. I was very surprised. And as for the parenchyma sparing hepatectomy, it is easy and important to preserve the major vein, and because collateral pathway can preserve the hepatic function, liver function, and maybe sometimes reconstruction is possible. But sometimes it is, for me, sometimes it is difficult to preserve a major Grisonian pedicle. The tumor, when the tumor is very closely attached to the hepatic hilum, in such a situation, how can you do the parenchyma sparing hepatectomy in such a situation?
I agree with you. The possibility to to detach from the Guisonian pedicle does not let you do what you can do with the hepatic vein. You don't have the chance of the partial resection, then detachment or amputation. In some circumstances, we accept when you have a condition that is formally unresectable. What do you mean? What do I mean? If you have a tumor that is at the posteriorly to the portal bifurcation, right and left, you cannot do a right and left hepatectomy. This means a total hepatectomy. And then if you want to resect, you have to challenge the R1 vascular, and sometimes you realize that the R1 vascular is not complete at the end of the resection. In this case, we challenge the burning of the capsule.
Burning the capsule. Oh.
With the electrocautery.
Oh.
Of course, not leaving macroscopic tumor, but if the detachment was not, we burn the Guisonian pedicle. It's exceptional, but we do that. But these are conditions that that has no other solution, because are always related to contact, extensive contact with the bilateral situation. Otherwise, we proceed with the amputation of the vessel.
Is the resection of a bile duct and followed by the reconstruction justified?
No. Burning of we do not enter in the Guisonian pedicle.
Okay.
We do not enter in the Guisonian pedicle. If we have to enter in the Guisonian pedicle, it should be amputated.
Okay. This is the last question about the fusion imaging. The accordance of imagings of the preoperative CT or MRI and the IOUS is very important for the navigation, intraoperative navigation. But in my personal experiences, it is not so. It is always successful. It's not so always successful. What do you think about the significance and the role of fusion imaging in the present and in future?
Yes, I think that it should be improved. Nowadays, the matching is not really exact, perfect. Then you need expertise in the ultrasound, and but for me, in practice, the real use is that I have the two images on the screen, and even if they are not completely matched, I used to move repeatedly the probe, which means I move also the image, and I can select which one. I can select to move even in the air the probe, and I move the scan of the CT or MRI. In this way, I recall every time where the lesion and the cluster were, and I need to recognize the position on the ultrasound of the ghost lesion in relation with the major vessel. And this is helpful. And also another aspect which is helpful is this combination of the fusion and also on the screen of the OR, the liver cast that is continuously showing me which was the pre-chemo setting of the disease.
I hear about the smart operation theater in other institutions. I don't see directly, but maybe such equipment may help the development of real-time future imaging or navigation.
I agree with you.
Maybe.
I see, and I saw that there is a possibility, there is already some technology that may read the deformation of the organ. Okay. I have seen it in some video, but this should be the task of the engineer of the Fuji.
Yeah, I agree with that. Thank you. The 10 minutes left, but discussion is very fruitful, and I think this session will be closed. Okay.
Thank you.
Thank you very much, Dr. Professor Torzilli. Thank you for your nice lecture. Thank you so much.
Thank you very much. Thank you. Bye.
Thank you, Professor Hasegawa and Professor Torzilli. Thank you for attending the seminar. What did you think of the seminar? We would appreciate it if you could answer from the following URL. That's all for the end of the Fujifilm Healthcare Corporation co-sponsored seminar.